So, my dear friends, welcome to this unique webinar on post-COVID complications and the importance of thoracic surgery in managing these complications. Today, I invite Dr. Nazir Yusuf, who doesn't need any introduction in India, and he's very well known across pulmonologists particularly because he's known for his generous training programs, observerships for pulmonologists across India from Kashmir to Kanyakumari. So, Sir has obtained his MBBS and Masters in Surgery from Jawaharlal Nehru Medical College, Aligarh. He specialized in cardiac thoracic surgery at KMC Manipal and secured the gold medal. Dr. Yusuf further trained in UK. He telescoped those skills to Fatima Hospital, Calicut, where in 1998 the first bypass surgery was performed in Malabar. With the mushrooming of many cardiac centers and the cry and cough of lungs were drowned, and the thoracic surgery took a backseat in India. His response was to pioneer keyhole surgery of chest. His hallmark surgeries include operating on a critically ill 5-day-old baby with the pus in the heart, and on a 105-year-old man with a burst lung and removal of 2.5 kg tumor from the chest, reported as one of the largest tumors ever. Dr. Yusuf was invited to perform the first live workshop in India on thoracoscopy at the National Conference in 2010. He was the organizing chairman for the national workshops in chest for 2 consecutive years, 2019 and 2020, a record in itself. To his name, he has got many publications in scientific journal. To his name, he continues to give lectures at various platforms. He was the past president of Calicut Cardiology Club. Dr. Yusuf's interest stretches beyond the professional realm to Freemasonry, Roundtable, MES, MSS, Cisco. His strong sense of service is highlighted by the contribution in the treatment and rehabilitation of victims of the Chernobyl nuclear disaster in the early 1990s. He is an associate professor and adjunct faculty in Manipal University. Presently, he works in Calicut in chest and PVS hospitals, in Kochi at Sunrise Hospital and Kim's Group. His achievements and contributions were recognized in 2004 when he was awarded the prestigious Vijay Shri Award in 2018, and he was honored by Indian Institute of Management for his contribution to medical tourism. And with this short intro, I would love to invite my dear friend, and he's like my teacher figure, Dr. Nazir, to take over from now. Thank you, sir.
Thank you so much, Dr. Harshvardhan Puri, for those glamorous and lovely words. I hope I can live up to your expectations as well as to the CCI. My talk shall be on post-COVID lung sequelae role of surgery. It's just a matter to open up discussions. So I shall not be going into great detail. Also, I should thank the backbone, the spine, the very person, the only one and very person, Dr. Krishna, who has done a wonderful job all these years to bring together young talent of the country. COVID is similar to tsunami. Tsunami strikes for a couple of hours and passes off, leaving a trail of destruction, loss of property, lives, and livelihood. Similarly, COVID, which leaves the body within 2 weeks, but at times has a devastating impact primarily on the lung, brain, and the heart. The number of cases and the death is quite imposing. However, some of these patients may benefit from surgery, but no guidelines exist for patients who require surgery for post-COVID lung complications currently because there's a lack of evidence or precedent. We at our center are happy to say is a part of a multi-center trial based in Italy. Few surgeons and centers venture into this uncharted, unknown territory. However, what we have found in our limited experience is that certain group of patients do benefit from surgery. The course which is of concern to us is that the patients may have crippling fatigue, continued breathlessness, cough, hemoptysis, chest pain, recurrent infections for weeks and months, even after COVID has left that body. These issues are not limited to patients who suffer from severe COVID, but also are seen in even those with mild form of infection. The more serious complications include lung fibrosis, leading to breathlessness and clots in blood vessels. Numerous tests and various modalities of treatment are required. Most survive, however, in a certain percentage. Mounting expenses on a daily basis lead to an economically drained, frustrated, dejected, and depressed patient. However, every cloud has a silver lining. This young boy flew in from Jalore, Rajasthan, with a ruptured lung with a BPF, which was following COVID. He had a hazardous journey, but eventually made it, and this was in the early days, sometime in April 2020, one of the first cases in the country, which we adventurously, boldly went in and operated, having little experience as to how to manage the case, how to deal with COVID, but using the available knowledge, we went ahead. The rationale in COVID. Lung fibrosis, as we all know, is one of the main reasons for shortness of breath. And if the disease is generalized, the treatment then, as we know and practice, is medical management. When medical management fails, in certain patients, lung transplant. However, if the disease is localized, such patients we could possibly consider for early surgery and almost complete recovery. And these are areas like localized pneumonia, cavity, aspergilloma, mucormycosis of lung, empyema, bronchopleural fistula, localized bronchiectasis, infected pneumatocoel, bulla, pulmonary thromboembolism, pulmonary infarction. That area of PTE and pulmonary infarction, we have very little experience. Now coming to the specific conditions, when the infection is confined to a local area, say in this particular case, in the lower lobe region, one could consider the right lower lobe, one could consider resection, and patients have persistent symptoms like cough, fever, chest pain, breathlessness. Sometimes a cavity develops in this infected area, and which may enlarge, causing further breathlessness. However, the progression of the disease is stable in the lung. This cavity can cause bleeding and recurrent infection. And this would harbor a fungal infection causing aspergilloma and massive bleeding. Again, local resection cures the problem. In certain cases, what it could cause in COVID, black fungus, which we are all familiar with, a rare disease, but mostly affects the paranasal sinuses, orbits, brain, and sometimes the lung. Mostly it can be treated medically, but at times surgery is required, and this is what happens in the lung. As you can see, with time, bilateral infiltrates then can come down to a localized area, the rest of the lung clearing up, however, a patient continues to have symptoms and required surgery for his alleviation. Another area which is pretty common is this condition called empyema. Usually starts with an empyema, then at times, as I shall show you shortly, the lung surface is so fragile that it bursts, ruptures, multiple abscesses occur, and a BPF is formed. So you have a air fluid level, complete collapse of right lung, patient not improving with medical management and conservative measures like chest tube. Why so? As you can see here, is as we go in, those are on the right side, so 3 lobes, but it's all pus. It is all the entire, almost the entire lung. Look as in the right lower lobe, you can see infected areas all through. So this particular patient had not only fibrosis below the pleura and a small collection of lymphocytes and intravascular hemorrhagic thrombosis on pathology, the patient had multiple areas of leak. As is witnessed clearly here, this is the hole, this is the perforated area of the lung, this is the underlying lung abscess, which is ruptured. And therein is, you can see, we instill fluid into the pleural cavity, ask our friends across, as the anesthetist to back, and clearly see where the bronchopleural fistula. The challenge here is this can normally be closed with stitches. However, please remember there are 3 conditions which are extremely difficult to operate and treat. They are tuberculosis, malignancy, post-radiation, as well, and now COVID. Of the 3, COVID lung is so stiff that stitches tend to cut through. This is an endothelialized, epithelialized bronchopleural fistula. So surgery does help patients recover from post-COVID complications, as was evidenced, and this was one of the first cases of empyema we did. Now, the infection, when it clears up, leave a destruction behind. The infected portion of lung is permanently destroyed by bronchiectasis, multiple number of small cavities, which appear like honeycomb. This can only be treated by surgery. Otherwise, with time, this keeps slowly invading the neighboring structures and the lesion becomes bigger. Hematocele. This is fairly commonly seen in patients with COVID. Most of them get resolved and medically and do not require any further intervention. This is due to a diffuse alveolar damage followed by necrosis of the airway walls with it that can cause this hematocele. Presence of ground glass opacities, air-filled thin wall cystic lesions. This is so because it's predominantly a peripheral lesion and subpleural in distribution. Rupture of the pneumococele in turn may be the trigger for occurring of pneumothorax, pneumomediastinum, and pneumopericardium. The size of COVID-19 related pneumatoceles is also highly variable, with some falling in the category of giant bullae. Pneumatoceele inside would be clear. In bullae, you could have striations, separations within the bulla. And this is a pretty large bulla post-COVID. And we're now going in scopically into the pleural cavity just to demonstrate see the surface of this bulla, which shows multiple blood vessels, the pretty thick wall as compared to pneumaticine. This particular case, the patient was quite dyspneic and breathless. We decided to remove the bullae. There were multiple bullae. Release the adhesions, and thereafter fired a stapler at the base. Sometimes we need multiple staplers. And whatever the rest of the bullae, which would be small bullae on the surface, can be cauterized. This is staple surface. This is bullae being cauterized, the rest of the lung. Yes, now pulmonary thromboembolism, we do know occurs, but we have had no experience in an emergent situation. But as you can see in this particular patient, this bilateral thromboembolism, multiple opacities, and there is all, you can see the diseased areas. And when we do an iodine map, a triangular area was found, which is almost dead, peripheral pulmonary infarct. If this patients, if they have symptoms, can easily be attended to by excising this area. Now, briefly, we just run through what patients we can help. Is there are more questions than answers because the current evidence is very little data, there is a paucity, and there is no precedent. The challenges we face are why surgery, that you've realized, because it is can be done in certain cases, as we discussed, where it is local. Who is a candidate? That is a big question. The patient should have minimal comorbidities, but usually they have diabetic and associated lung problems, but kind of optimize them to a reasonable effort to about 80% of FEV1 predicted and exertional dyspnea to a minimum. Saturations around 94. And where to do? Of course, identify the lesion localized, the bulla or the lung part, which is affected. We can resect that area. When to operate is a big question. Obviously, it should be after the patient becomes COVID negative. But what we have found that as long as we can push it, the longer we can push the surgery, that gives time for the lung to recover. And what is the outcome? It's very good. Very encouraging results we have. Now, what the American Society of Anesthesiologists and the American Patient Safety Foundation issued a joint statement for when to take up these surgeries. But this is for elective patients and not for lung surgeries. But we can extrapolate and logically look at it. Pulmonary function continues to recover up to 3 weeks. Suggested wait times would be anywhere between 8 to 16 weeks, especially if the patient is diabetic or immunocompromised. And maximum leverage we get and time for rehabilitation for the lung. And this is what we aim for. Saturations around 98, 91 to 98 will be fine. Usually this is seen in 6 to 16 weeks. Ideally, about 12 to 16 weeks, we get patients getting up these saturations but have symptoms. And but when they exert, saturations will drop in these patients. FVC around 3.72, percentage of vital capacity, 106 is what we would like to aim for, but after a while it stagnates. Then there's no point waiting. FEV1 around 2.55, and similarly the percentage. D-dimer should always be preferably less than 0.5. Finally, we found an incidental benefit in patients with COVID when they've been screened, or CT scans throw up surprises like detection of early TB and its complications. Cancerous and non-cancerous both have been diagnosed, which could otherwise have become serious in the future. This we share our experience, and that was published. Ours is a limited experience. We have had one mortality and major complications. One, the numbers are not huge, but working in the private sector, we have our limitations. quality of lung improves, quality of life improves, patients can ambulate with minimal or no requirement of oxygen, thus converting them from respiratory cripples to productive humans. Patients are relieved of their symptoms like cough, breathlessness, hemoptysis, fever, etc. Excuse me. Surgery may be done through minimally invasive techniques through multiple small incisions. The points to ponder we have discussed is that surgery is definitely an option, but again, that selected group of patients with post-COVID lung ailment, like localized pneumonia, cavity, aspergilloma, mucormycosis, empyema, BPF, localized bronchiectasis, infected pneumococele. These are areas, and of course, in pulmonary infarct may be considered. However, believe nothing, no matter where you read it or who has said it, not even if I have said it, unless it agrees with your own reason and your own common sense. A little bit of philosophy, take-home thoughts, years of experience. Buildings and machines, my dear friends, do not create patients. God, through your hands of doctors, treat patients. Please think out of the box, challenge guidelines logically, be the difference, and be the change. And finally, please remember to cure sometimes, to relieve often, to comfort always.